Imagine this. It's 2 in the morning. You're alone in the ER with a complicated patient and you need the help of your attending. You pick up the phone, you dial the number, and you're nervous. What the hell are you going to say so he doesn't think you're an idiot? Hello and welcome to learnabouteyes.com. In this episode, I'm going to teach you how to present a patient to your attending physician in the most efficient and professional way. Presenting a case is a key skill for every doctor. And learning this early on will not only help you make a good impression with your superiors, but also help you think in a structured way for every patient so that even the most complicated case is not a problem. This video doesn't only apply to ophthalmology residents. The same structure can be used for every specialty, and it can be used to present patients on the phone as well as in person. So let's go. The main problem I see with my residents is that they're always so afraid to forget something important that they just tell me everything they know about the patient. This usually leads to very long and complicated presentations. So your first lesson should be, if your attending is asking for more details, that does not mean that your presentation was bad. If he's asking for details that you already told him, that means it was very unstructured. Here's the structure I want you to use. Pause the video, take a screenshot and save it on your phone. Or memorize it. We're going to go over each point in detail later on. But first I'm going to give you an example of a bad presentation.
Hi, I just saw Miss Anderson. She has a really red eye and she can't see much and she has pain. It started a couple of hours ago when she was on the way home from her son's birthday party. His name's Sam, by the way. And funny story, he's in med school and wants to become an eye doctor too. So I took the pressure. It's 56. And the angle is closed too. I did an OCT. But the lids look fine and the retina as well. So what should I do?
This presentation was completely unstructured and focused on unimportant details while leaving out important information. So now let me show you how a good presentation sounds. First, we're going to go through it step by step, and afterwards you're going to hear the whole thing at once.
Hi, this is Lorenz.
Always introduce yourself.
I'm a first-year resident at the University Eye Clinic, and I'm calling you from the ER.
This part really depends on your situation. I know all my residents by name, so I don't need the job description. But I like to know where they're calling from. It's a huge difference to me whether you're examining an intubated patient in an ICU or looking at a scheduled follow-up in a private practice.
I have a 45-year-old Caucasian woman.
2 comments on that. First of all, please always calculate the age. Don't be lazy and just give the year of birth. Secondly, always mention the gender. The race may not be as important depending on the diversity of your patients.
Presenting with blurred vision, pain and redness in her left eye since 2 hours.
This is a part that a lot of young residents struggle with. Don't just repeat back what the patient said. Condense it down to the essentials. Let me give you a little example. A patient might tell you, I was watching TV last night. Do you know that show Friends? It's really funny, right? So all of a sudden I saw Chandler twice. At first I thought it was a special effect, but then I noticed that the whole TV was double as well. And the lamp too. And then I got up and I was walking like I was drunk. Isn't that weird? So please don't tell your attending any of that. Condense it down to, I have a patient with sudden onset of double vision and balance problems 8 hours ago. One of the key skills of every doctor is to take a patient's story and convert it into a list of symptoms.
She has no other previously known health issues.
Here, I want you to paint a picture how sick your patient is. But don't just list everything that you found out. For example, don't say, well, this patient had a Zen implant in June 2015, and then a trabeculectomy in November 2015, and then a needling in December 2015, and another needling in February 2016. And then we did a bleb revision in March 2016, and also again in March 2017. Yes, your attending might need all of this information later on, but in your initial presentation, you're just going to say, I have a patient with multiple glaucoma surgeries.
I measured a visual acuity of 1.0 on her right eye and only 0.25 on the left. The IOP was 16 on the right and 56 on the left.
There's not too much to say about that part. When you're listing measurements, make sure you're always listing them in the same structure. So always first right, than left, and emphasize with your voice on the ones that you think are important.
The slit lamp exam of her left eye showed a 2+ conjunctival injection, a hazy corneal stroma, and a very flat anterior chamber. The pupil is wide and unreactive to light.
This is the second part that most residents struggle with. Especially if you don't know what the patient has, you tend to list every single thing that you've found. If you don't know what is relevant, here's a little tip. Take your list of symptoms and try to match them with your findings. Let's take this case as an example. The patient has a red eye. What structure makes it red? Is it a conjunctiva, episclera, sclera? What's causing the redness? Is it bleeding? Is it hyperemia? This patient has blurry vision, so go through all the refractive parts of the eye and check whether there's a problem. Is it the tear film, the cornea, AC, lens, vitreous, retina, optic nerve, or even the brain? Please leave out anything that has nothing to do with the symptoms. If your attending needs more information, he can ask about it. As I said in the beginning, it's not a sign of a weak presentation if your attending has to ask for more specifics. It's only a sign if he asks you to repeat things that you've already said.
The right side looks pretty normal apart from also having a flat anterior chamber.
This kind of goes into the same topic as before. If there's nothing to be found, just say it's normal. Don't list every single thing that is normal and has nothing to do with the symptoms. If I want more details later, I will ask you about it.
The anterior segment OCT I just did showed a closed angle on the left side.
Now this part can be kind of tricky, especially if you're new and you can't really interpret all the additional examinations that you make. If you can, try to interpret everything you've done. If not, take a screenshot or picture and send it to your attending.
In my opinion, we're dealing with an acute angle closure attack. I think we should give the patient Diamox and pilocarpine and check the pressure and cornea again in 1 to 2 hours. What do you think?
This part is very hard for beginners, but I strongly urge you to always write down what you think the diagnosis is and what you think we should do as a treatment. Because believe me, if you never do it, one day you're going to sit alone in your private practice and you're not going to know what to do with your patient. If you're not sure what exactly the problem is, at least try to define a category. Is it infectious, inflammatory, genetic? And if you have no idea what the treatment could be, at least suggest what type of medication could help here. Steroids, antibiotics, whatever. And just a quick additional note. Please don't call your attending in the middle of the night before having done all the necessary examinations and before having read about the case in your book. Okay, that was already it. I hope you learned something. And before I play the whole presentation for you in one piece, please don't forget to subscribe, like the video, and hit the notification bell icon. If you have any more questions, please don't hesitate to ask in the comments below the video. See you in the next one.
Hi, this is Lorenz. I'm a first-year resident at the University Eye Clinic, and I'm calling you from the ER. I have a 45-year-old Caucasian woman presenting with blurred vision, pain and redness in her left eye since 2 hours. She has no other previously known health issues. I measured a visual acuity of 1.0 in her right eye and only 0.25 on the left. The IOP was 16 on the right and 56 on the left. The slit lamp exam of her left eye showed a 2+ conjunctival injection, a hazy corneal stroma, and a very flat anterior chamber. The pupil is wide and unreactive to light. The right side looks pretty normal apart from also having a flat anterior chamber. The anterior segment OCT I just did showed a closed angle on the left side. In my opinion, we're dealing with an acute angle closure attack. I think we should give the patient Diamox and pilocarpine and check the pressure and cornea again in 1 to 2 hours. What do you think?